So screening with CT, and this was debated a few months ago as well, but ultimately using CT for asymptomatic patients is unlikely to be a useful use of our resources for a couple of reasons. When we don't have a great community prevalence of infection, your yield will be very low. And when we do have a greater prevalence, we will likely overrun our CT resources due to the time it takes to clean the scanner, because we'll have more patients who end up being positive. And even if we had enough patients with infection and we didn't have to clean the scanner, even with that, less than half of the patients who are asymptomatic but positive will show CT abnormality. But in terms of triaging symptomatic patients with CT, then it becomes a more difficult discussion. The PCR tests are not 100% sensitive. They vary in the literature between 42 and 71%. Now, the more recently introduced tests do have a greater sensitivity. However, it does, as I said, relate to your technique as well as how you've handled and stored the specimen. It may take up to 4 days for an initially negative PCR patient to convert to being PCR positive. And that's a problem for an unwell person in your facility. The CT findings in your symptomatic patients really depend on how long it's been since they developed their symptoms, and I'll go through that as well. And in the first 2 days of being symptomatic, about 50% of patients still had a negative CT. Between day 0 and day 4 after developing symptoms, you are more likely to have infection on your CT. And by day 6, you will generally have positive findings on CT. So the important message here is you cannot rule out a COVID-19 infection with a normal CT. It doesn't help you exclude the infection, particularly in the first 4 days after the onset of symptoms. So the Fleischner Society came to the party and had their statement on the 7th of April. And the important thing to note about this was that this was a consensus statement involved by both clinicians in radiology, but also respirology and infectious diseases. And these physicians had been involved in the epicenters from this pandemic. And they had a few summary points, and I'll go through some of the scenarios they debated, is that imaging was not indicated if you suspected infection, but they were very mild clinical features unless the patient had risk factors for progression. But it is indicated if you have a patient who's infected and is clinically deteriorating. And if you have an environment where you're resource constrained, and that means you're overrun with infection, it is indicated to triage patients with suspected disease who are unwell, and you have a high pre-test probability because of the pandemic situation you find yourself in.